Hello, I'm Tanni Grey-Thompson, ex-athlete, crossbench peer and co-chair of Living in Dying Well. And I'm joined today by Robert Preston, a former Whitehall civil servant and parliamentary clerk, and he served the Mackay Committee into their in-depth inquiry into assisted dying in 2004 and 2005. And he's been director of the think tank Living in Dying Well since its foundation in 2010. I'm also joined by Ilora, Baroness Finlay, Professor of Palliative Care, a crossbench peer and also a member of Living in Dying Well. Now, we're here today to discuss, Ilora and Robert, your new book, Death by Appointment. And I think it's really important that we talk about assisted dying, but also debunk a lot of the myths that are out there about it. Now, there's a lot of information out there about assisted dying, not least in the press at the moment. But why did you feel the need to write a book to challenge some of the arguments that are out there, Robert?
Yeah, this is a very important issue. It's quite literally a matter of life and death when you think about it. Think about it for a moment. The criminal law now says that we must not involve ourselves in deliberately bringing about the deaths of other people. Now, what's being proposed is an exception should be made to that for certain designated categories of people. Now, on any definition, that is a major change in the law, and we need to have clear understanding of what we're doing if we're to make that kind of change in the law. So what information is out there? Well, actually very little. Most of what we're seeing is slogans, sound bites, bland assurances that all will be well, and wild statements that everything is in the garden is lovely where these laws have been made. It just isn't true. There are no explanations given of the things we need to understand if we're to make a decision on this. We're told, for example, that the law is cruel, but we're not told what the law is or how it works or what's its effect. There's also, and I think a second reason for writing the book is that there's been too narrow a focus in the debate. Those who want to change the law tend to pick on individual issues like control at the end of life. It's about more than that. Yes, it's about control at the end of life, but that's just one of many facets. It's about the law. It's about how doctors treat patients at the end of life, what the medical ethics are in this subject. It's about the way society has changed over recent generations. And not least, it's about the experience of the minority of jurisdictions overseas that have chosen to go down this path. Now, what we've tried to do in the book is to address each of these facets of this complex subject and to show, so to speak, how the jigsaw fits together.
And well, none of us are neutral in this debate because we all have, quite strong views on why we don't want the law to change. But we probably come at it from different points of view. Me as a disabled person, I'm worried that it'll be used as a way to get rid of disabled people. But how do you reconcile your position of opposing a change in the law with, informed and objective discussion?
I think it's really important to look at all the evidence that's out there and to try to look at it from both sides and then come to a conclusion. And that's what we've tried to do. We haven't pretended that we don't have an opinion, having looked at the evidence. But then having looked at the evidence, more and more is coming forwards. I'm looking at it from the perspective of a doctor and the responsibility that this would put on doctors' shoulders. And I think all doctors need to know what is really involved.
If I could just add to that, Tanni, there's a burden of proof here. There are certainly arguments on both sides of this debate, but the burden of proof rests on those who say the law should be changed to make their case and provide the evidence for what they're saying. Now, that burden of proof simply hasn't been shouldered. As I've said before, all we're really getting are bland assurances. We're not getting explanations. We're not getting the material or the evidence on which to make a decision. Now, in our view, at the very least, the evidence does suggest it does raise serious doubts about whether the law should be changed. But readers must make up their own minds. It's not for us to ram things down people's throats. They must make up their own minds. But as we say in the introduction to the book, if it's caused some people to stop and think, it will have achieved its purpose.
I know when I came into the discussion at the very beginning, I was very much keen on personal choice. But then for me, you look at the safeguarding of the jurisdictions, you know, how once the doors opened and actually how little choice a lot of disabled people have, that made me sort of think, you know, just really seriously about this and think twice about just changing the law, you know, because it feels the right thing to do. And Robert, you said at the beginning that, you know, there are a number of people who say that the existing law is cruel. What would you say to somebody who says that, you know, that it doesn't allow someone in great pain to bring their life to an end? And actually, then, Ilora, I'd like to come to you because you work in palliative care. This is what you see day in, day out. But Robert first.
Yes, we take this issue of pain. The case for changing the law is very often presented in terms of pain. I mean, anyone who knew nothing about this would think that people were dying in agonizing pain all over the country. If you look at where these sort of laws have been introduced, and let's take the American state of Oregon, because that's the model for the campaigners here. Look at the official reports that come out every year and look at the reasons why people who have taken their lives in this way give for having sought lethal drugs. Pain is next to the bottom. It's at the top, and I quote the words, less able to enjoy life as it was before. Pain is not, only in 33% of cases did people cite pain or the fear of pain. Not enjoying life as much as before, 90% of people said that. And suspiciously, halfway down the list is another factor, fear of being a burden on family and friends. That's something that needs to make us think here. So perhaps I should just be quiet at this point and let Ilora talk about pain relief, because my understanding, Ilora, is that pain relief is actually now very much better than what it was a generation or so ago.
The science of pain relief has moved on phenomenally in recent years. When I qualified, in all honesty, we really didn't know what to do in pain control, particularly not in people with severe disease. If you're ill and you're in pain, you need to know that you'll be looked after by people who know what to do to relieve your pain. And if they are stuck, that they will seek help from other people. You don't have to end a person's life to end their pain. But the other thing to remember is that pain is a multifactorial experience. And therefore, if people are distressed because they're frightened, they're worried, because they feel that they're a burden or whatever, their physical experience of pain is made worse. Pain requires you to look at the physical cause of the pain and holistically treat the whole person. When we think about choice, if you're in pain, what's the choice you want? You want to be seen by somebody who knows what to do. If you're in possession of lethal drugs, there is actually a burden about deciding at what point do you take them. But I'm not sure that gives you any more choice, because the choice you want, if we talk about pain, is to have your pain relieved and relieved properly.
And isn't part of the issue that, you know, we have great palliative care in this country, but it also can be ad hoc in different parts of the country?
I'm afraid we have fantastic palliative care, but its provision is patchy and it isn't 24/7. And the sad reality is that crises arrive in people's lives out of hours, not in the working hours Monday to Friday, 9 to 5 or whatever. So we do need to address that services really change to provide 24/7 support. But again, providing lethal drugs doesn't solve that problem. So we've identified a problem that, yes, people have in the past died badly. Now far fewer are dying badly, but it isn't always perfect. But the solution to that problem isn't giving people lethal drugs to end their life.
Yeah, but Tanni, if I could just add something to that. I mean, what we've been discussing here reveals one of the great paradoxes of the assisted dying debate. If I go back to my childhood many years ago, people really did die in pain, quite commonly. because there was very little, as Ilora said, that doctors could do in those days to relieve pain. That the science of analgesia wasn't understood in the way it is understood today. And yet nobody talked about legalizing euthanasia. Nobody even invented the euphemism assisted dying. Since then, the science of pain relief has advanced by leaps and bounds. Britain has been judged in 2 reviews by the Economist Intelligence Unit in first place in the world for the quality of care at the end of life. And yet in parallel with that, we've seen campaigning to change the law. It doesn't make sense.
You both say in chapter 2 of your book that terminally ill patients have the right to stop treatments that will save or extend their lives. So if they want to die, why can't they just ask their doctors to supply them with the means to do so?
Can I try and answer that, Tanni? Because there's a fundamental difference between accepting death, when you say, I can see this treatment is not doing me any good, I am going to die, I want to be looked after as I die, and the other, which is seeking death deliberately months or even years before death would come, and when you have no idea what else lies ahead. So, yes, you cannot be treated without your consent, and you cannot have ongoing treatment without your consent ongoing. If you take chemotherapy for cancer patients, many patients will get to the point they say, I don't think this is doing me any good. I think it's doing me more harm than good, or it's too much of a burden. I want to stop, and they must be looked after during however long they live. And that's quite different to them saying, I'm frightened of what lies ahead, and I therefore want to be given lethal drugs to end my life months or years ahead. Because actually some of these patients, when you stop their treatment, feel quite a lot better, and they can live well for quite a long time.
Yes, I mean, it is the difference that Ilora has highlighted. A patient who wants treatment to stop isn't expressing a death wish. The patient is saying, I've had enough, I'm accepting death, I'm prepared to let the disease take its course. That is totally different from going to a doctor and saying, give me lethal drugs so that I can take my own life.
I want to come back to something that you both talked about earlier, and it's included in chapter 6 of your book, which is the title of the chapter is The Moral Dimension. A lot of the reasons that people have given for assisted dying are not what most people would think, and they're personal or social rather than medical. And I was really struck by an earlier comment by a colleague where she said, and this is not flippant, but she said, where there's a will, there's a relative. And for me, that stood out really starkly in terms of what she's saying. But what about, the doctors who will be forced to take these decisions? Do you feel that they're equipped to take these decisions? Should they be taking these decisions?
We've pointed out, based on the data, the official data that comes from Oregon, that most of the reasons that people have opted to seek lethal drugs is because of social factors, not wanting to be a burden, not enjoying aspects of life. Doctors don't know what goes on behind the closed doors in somebody's home. They cannot judge if somebody's under pressure. They cannot judge if they're being made to feel a burden. They cannot judge if the life insurance policy is going to run out and the family want that money, I'm afraid. Most families are loving families, but they aren't all loving families. We know that there's abuse out there. We know that there's abuse in our society, but doctors are not in a position to state in law there is no coercion and that the person really understands what they're doing.
Yeah. Yes, it's interesting, isn't it, that there's a half realization of this on the part of the campaigning groups, I think, because in the last year or two, they've added something to their proposals. Not that 2 doctors should be satisfied that somebody meets all the criteria, but that a judge of the High Court should confirm this. Now, that is not what it seems to mean. I mean, it's one thing to say, if you want to have legalized assisted suicide, go to the High Court, let the High Court investigate the case and reach a decision, balancing the medical factors, the social factors, the personal factors. That's one thing. All this is saying is doctors will still make the decision and a judge will rubber stamp it.
Thank you both. There's a huge amount to think about in this debate, and thank you for sharing your thoughts today on your new book, which is Death by Appointment, available in all good bookshops. I've always wanted to say that, and also online. So Ilora, Robert, thank you for joining me today, and you can find out more information on the Living and Dying Well website. Thank you.